Hi, I'm Ashley Cooley, a birth, baby, and sleep specialist and mom of 3. There's so much information out there, right? This show is dedicated to helping you clear out the noise so you can figure out what will work best for your baby and your family. If you're looking to learn more about your baby, gain more confidence in your parenting, and get as much sleep as you can through it all, you've come to the right place. Bringing up baby is about to get a little easier. Everybody, this is Ashley. Welcome back. I have another episode for you with our friend Kelsey Marr. She's a doula and birth researcher, and she and I are chatting today about tearing and episiotomies. This has to be one of the biggest questions that she and I both get. These are big questions, and among the top when it comes to childbirth prep is people are concerned, the birthing person primarily is concerned about tearing or needing an episiotomy or getting an episiotomy during childbirth. And so we're going to talk about it. We're going to actually talk about what the research says. How often is an episiotomy performed? How often does tearing maybe happen? Are there any ways to avoid or prevent these things from happening or needing to happen during childbirth? For instance, a lot of people will hear about perineal stretching or these little exercises you can do in the perineal area. And does it even work? What does the research say? Is this going to be helpful? So we're really going to break down tearing, episiotomies, the good, the bad, the ugly, and the stuff that we need to hear. So without further ado, here's my chat with Kelsey. And as always, if you have any questions about this or would like to chat about it further, I'm more than happy to reach out at ashley@birthbabysleep.ca or find us at birthbabysleep on Instagram. Love to chat. Happy to answer your questions. But have a listen. Enjoy.
Well, you and I both find when we're meeting someone prenatally that this is kind of top of mind. I think I was more afraid of tearing or an episiotomy, whatever was going to be in my future. I was more afraid of that, I think, than actual labor, like the rest of it, because it just seemed really scary. So I would love for you to help break this down for us of like, what does it mean to have a tear and episiotomy? Like, how can we avoid it? That's probably the biggest question. It is like, I don't want this, so how do I avoid getting it?
Yeah.
Is there a way that we can avoid getting it? And yeah, so let's just start there. What are your thoughts on tearing? What does the research tell?
This is like the number one thing that comes up during my consults with new clients when we talk about like what's important for them in their birth and their labor. It's always like, I don't want to tear. And so I think in understanding that, we really need to have a good understanding of what tearing or an episiotomy means. And so specifically, we're referring to like tearing or trauma to the perineum, which is that space between kind of your vaginal opening and your rectum. Sometimes I explain it to people as like the part of your body that like actually sits on a bicycle seat. It's like that that space there.
Yeah.
And so when we're talking about how to avoid tearing or whether or not tearing is going to happen, what we're really talking about is protecting that tissue from any trauma that might happen during childbirth. I think one of the things too to really clarify is that not all tearing is equal. So there's 4 degrees of tearing that we commonly talk about, and there's some more complex categories within that. But 1st degree tearing is really just a like slight separation in the skin around the vaginal opening. From my experience being in the birth room when somebody has 1st degree tearing, and the doctor is repairing that tear, it looks very, very minimal. Sometimes it just looks like the top layer of skin in the vaginal opening is lifted. So we're not talking about like a big fissure or a big like rip in your tissue, right? 2nd degree tearing gets more into the muscle between your vagina and your anus, and both of those are considered kind of, I don't want to say they're not severe, because to the people who experience them, they can be, it can take additional healing time. It can be uncomfortable. It can be a big experience. But then we classify them as less severe. Right. There's something that's going to be typically addressed within the birthing room. So you give birth, your baby's on your chest, you're having this lovely moment, and more than likely not even aware that the doctor is putting some stitches in to hold together that first or second degree.
I have to say, I was aware and I did not enjoy.
Oh, no!
It was kind of like holding my baby up close to my face and then just being like, oh, ah! I didn't feel it fully. She did numb the area and stuff, but it wasn't like, oh, I just got an epidural, I don't feel my contractions. It was more like, oh, I got a little
And it would definitely depend on what sort of medication you're on, right?
Okay.
Like, if I see people who have a first or second degree tear and have an epidural, usually that part of their body is still numb to the sensation, and they're not feeling that. With third and fourth degree tears, we consider those to be more severe in that they're not they can't necessarily be addressed in the birthing room. They might be addressed within the OR for repair. And so with a second degree tear, we're really getting into the muscles of the anus, into that anal sphincter.
The second degree? Or
with the
third?
The third, sorry.
Okay.
And then with a fourth degree tear, we're getting up into the lining of the rectum and the anus. So that all sounds really scary, right? And it's for me, it's always hard to really relay what that looks like to clients, what that like visually looks like between those degrees of tearing. The Mayo Clinic actually has some really great visuals on their website that shows that. But really, when we're talking about tearing, we're talking about a common experience, and with those really severe tears, we're talking about very, very low numbers of people who would actually have that level of tearing. So about 50 to 75% of people experience some form of trauma to their perineum while giving birth, so some form of tearing. But that said, depending on what study you look at, those third or fourth degree tears, those ones that are going to take more attention and more time to heal, that's reported between 3 and 7% in some studies. In other studies, it's as low as 1 to 2%. So that's not to say that a first or second degree tear isn't something to be concerned about or something that we want to prevent. But in terms of these more difficult, more severe types of tearing, the likelihood of you experiencing that as a first-time parent is extremely low. And our rates of tearing go down with subsequent birth. So those numbers would be even lower if this is your second or third or fourth.
Right.
Yeah.
Interesting. So you said 50 to 75% of births will result in some degree of tearing. Most of those seem to be first or second degree tears.
Absolutely.
And so there's still a subset of people that are not going to have any sort of tearing.
Yep.
But of course our minds go to the possibility of like, well, I'm going to be that 1 in 7 or that 1 in...
And 50 to 75% is enough that we probably all know somebody who's been tearing. Or who has torn. And we also know that in sharing our birth stories, we tend to hear more of the negative than the positive, right? Yeah. So
people aren't jumping up being like, hey, I didn't tear. I had a great birth.
So we're more likely to hear about people's experiences if they tear. And I find I'm more likely in working with clients and talking with other moms, I'm more likely to hear about the people who had a negative experience with a tear than somebody who is, they had a first degree tear and it didn't really impact their postpartum. So I do think there is perhaps like some reporting bias that we hear in terms of whether that's in conversation with our friends or on social media about what the actual
I think everybody who's
is.
pregnant or has been pregnant realizes that, just like somebody telling you their story that you just met, or like their birth story, that they tend to go with those kinds of stories. And
absolutely.
Anyway.
And it can be hard if you don't have that type of story to feel like you can share it if you have a positive birth story.
So, okay, next then my mind's going to prevention. And so preventing tearing, period, would clearly be on people's minds. And, or if tearing is maybe likely to happen, is there a way in the moment even, or things happening too quickly, where we can maybe try to lower our risk of a more severe tear?
So there's kind of like the hands-off options that we see decrease the rates of tearing or the risks of tearing.
Meaning
and
what? Hands-off?
Meaning like they are decisions we can make in terms of setting up our birth early on to lower our risk of tearing.
Okay.
And then there's the things that we can do that is more like hands-on, personal. This is what we can do to prevent tearing. So we see decreased risks of tears depending on the model of care. So we see the lowest rates of tears with midwifery care, which can be hard where we live in Halifax, because we know that midwives are awesome. The care that they can provide leads to a whole bunch of really great birth outcomes, but we don't necessarily have enough midwives to serve our population. And part of the reason that we do see lower rates of tearing with midwives, we also see lower rates of those interventions where we would see more tearing or episiotomies. So we see less intervention with vacuum, forceps, or episiotomies in general with midwives. Your birth setting, so we see lower rates of tearing with home birth than we do in hospital birth. Again, for a lot of people in Nova Scotia, having that home birth would be dependent on having midwifery care, so that kind of goes hand in hand. As I mentioned before, your likelihood of tearing is higher if you are a first-time birther than if you have it's a subsequent birth. And then there's factors like higher birth weight of your baby, how long your pushing stage is. So if you have a very long pushing stage or a very short pushing stage, we see that you're more likely to tear. And then the fetal positioning. So if baby is sunny side up, so to speak, we see more tearing with that. Now, we can kind of, to different degrees, control who our practitioner is and where we birth. We can, with help with a doula, with research, or with an informed labor nurse. Hi, kitty cat. We can help a sunny side up baby rotate to decrease that risk. But one of the things that I talk to my clients about who are really fearful of tearing is working with a pelvic physio during pregnancy, because they are going to be, during pregnancy and postpartum, because they are going to be able to, one, help you understand how to push well, how to align your muscles to push well, which takes effort, especially if we're a first-time birther. We don't necessarily know how to do that. They can help you recover from a tear very well. We also talk about positioning, the doula's best friend, making sure that you're in a position where gravity is helping you rather than lying on your back. Or opting for a water birth can be a really great option too, where we see lower rates of tearing and definitely lower rates of episiotomies. Part of that being doctor can't
We're in the water.
get in there to give you an episiotomy. But those sorts of things can really help decrease our risk of tearing. That said, they're not going to prevent it totally, right? This is there's a lot going on.
Yeah, there's a lot of factors that have to line up.
Really. But those can definitely help.
Yeah. Okay.
Yeah. Or sometimes I see as the birthing person is pushing that the doctor or one of the nurses will put warm compresses on the perineum that can help reduce the risk of tearing.
Plus, it just feels better.
Yeah,
when when it's happening, because it's when the baby's head's coming out. Really, right? That's what's.
And you'll often hear kind of like birthing person will push, and then the doctor will they start crowning. Mm-hmm. You feel that ring of fire, and the doctor or the midwife will say, "Okay, hold on a second." And if we can't, it's hard because you have a fetal ejection reflex that makes you want to get that baby out. Mm-hmm. Plus the ring of fire is not fun for anyone. But if you can take that moment and breathe and hold on a sec to let that tissue stretch more slowly around baby's head, that will reduce the risk of tearing.
So good coaching during pushing and trying to slow down the push at that end point.
And that's really where I think working with a pelvic physio during pregnancy can be beneficial because I can talk to you about pushing strategies that are going to make having that tissue stretch in a way that's natural for that tissue work better for you, right? Like when you are we want to build as much muscle memory related to pushing during pregnancy as we can, because frankly, when we're giving birth, we don't really have the space to think about it. So we want it to become natural during pregnancy through practice, so that we're just relying on that muscle memory, rather than having to have to think about it for the very first time.
Yes,
when you're in it.
Yeah, totally. That makes so much sense.
Yeah.
Okay, so speaking of that, in other ways of preventing something, so we can't prevent tearing by stretching that tissue and use it, because you Google and there's things out there that say they can help prevent tearing, but it's really just for you to recognize that feeling of it stretching that much, so that you can coach yourself through that pushing and, like you said, be ready for that moment when it comes.
One of the strategies I hear promoted most often is perineal massage. Yeah. And it's it's a standard part of the curriculum in a lot of kind of birth education classes. But what we're actually seeing, in terms of the research that backs it up, we don't have great quality research. Maybe I'll back up. So for those who aren't familiar, perineal massage is typically you would insert 1 or 2 fingers just a couple of inches into the vagina and apply pressure downward for a couple of minutes, and then kind of side to side in a U-shaped motion. And some of the procedures around it or policies around it suggest doing it for a couple of minutes, 3 to 4 times a week during your 3rd trimester. Some say up to 10 minutes. And the idea is that 1, it's increasing circulation to the perineum, and 2, that it's stretching those tissues out to make it easier for baby to come out. Now, there are research studies that, and including a Cochrane review, a really high level study that suggests that perineal massage is beneficial. But when you break down the studies that, 1, go into that Cochrane review, and 2, the other studies that are out there, there's some real issues and flaws in their data. And actually, Evidence-Based Birth has a really great episode on perineal massage where they do a deep dive into those studies and explain why the data around them is flawed. So where that kind of leaves us at the bottom line is we don't have any evidence that perineal massage is going to be harmful. if it's something you want to try, if it gives you a sense of empowerment or control because you're doing something to prepare for your birth, absolutely go for it. I will caveat that by saying it can be quite uncomfortable.
Well, you can decide if you're going to continue to do it.
Yeah, you might try it once and then decide, no, thank you. But also, it's like the research that it's based on is really, really questionable. So what I would say in terms of reducing the risk of tearing, rather than perineal massage, what we do have good data on is education and communication. So educating yourself about what different types of tears are, what different types of trauma to the perineum are, what you can control and what you can't, and then communicating with your practitioner. So knowing what, for example, their episiotomy rate is, to have an open conversation with them about the fact that like tearing is a real fear that you have. And I know that some practitioners are more open to having those conversations than others, are more, some are more supportive than others, but really trying to have that conversation around, this is a priority for me. I'd like to do what we can to prevent tearing, or an episiotomy if we can do that.
Right. So speaking of episiotomies, what is that? And we were just talking earlier how luckily they are not routinely done. I know that this was, well, I shouldn't say I know, but like, I was born in the 80s, but that doesn't mean I remember all of it.
Yeah.
But in the 80s that it was routine, and maybe beyond that too, but it was like everybody got an episiotomy to make the vaginal opening a little bit bigger so that baby can slide out, I guess. And so like everything in the 80s, everybody got it, and we don't all need that.
So an episiotomy is a little cut that doctor will make in order to make the vaginal opening bigger.
With permission.
With permission. Hopefully
consent.
it's happening, knock on wood, with permission and informed consent. It was funny, before we started recording, I said as a doula at least in Halifax, I've never seen an episiotomy performed. You felt that they were far more common. And we've I checked in with the doulas, you checked in with a birth nurse, and we're getting, they are being practiced for reasons now. So one of the reasons it might be done is if we're looking at another intervention, like an assisted birth with vacuums or forceps, sometimes to get that instrument into the vagina, an episiotomy,
because baby's in distress and a position might be, so there's like a medical reason.
If a baby has shoulder dystocia, which means kind of their shoulder is stuck on the pelvic bone, an episiotomy might be made so that baby can be maneuvered out. Or if so as somebody delivers and pushes, it's potentially possible for a doctor to see a tear forming, and depending on where that tear might be going, whether it looks like it might turn into a severe tear into the rectum or the anus, the doctor may ask if they can do an episiotomy to guide that tear in a different direction, so that the damage is less severe to the birthing person. That said, we also know from the research that it can be more difficult to heal an episiotomy than a natural tear, just in terms of how the tissues come back together. But we aren't, I do hear from clients that they would really like to avoid an episiotomy because historically it has been done as a routine procedure, like you point out. Here we aren't seeing them done. The consensus
they're not done routinely.
Is they're not being done routinely.
But if someone, let's say, because that is a reason, and that was the reason I was given with my first, and I believe it because that baby had a big head. And so they would take it to more of a diagonal or just like going away from the anus. So if and making sense again of the tissues and the skin and going back together, that a natural tear would do that maybe potentially better. So what if the decision then becomes, do I allow my doctor to guide the tear in a different way just in case, or do I let the tear about to happen maybe going too far? Like, so there's just no right?
Right. And there's, I think one of the ways that we can kind of reconcile that, even though we're not gonna like know for certain in
that might not even be a
direction.
decision you have to make.
It might not be, but is to have that discussion with your practitioner early on. So have that discussion. You could talk about it with a childbirth educator, with your doula if you have one, with a pelvic physio. Ultimately, do have that discussion with your practitioner and recognize that this is a possibility that could happen. How are you going to, one, make a plan with your practitioner, get all the information, make a decision maybe prior to the actual situation. So like, if this comes up, this is what we're going to do, because then that gives you control over that decision rather than making a spontaneous decision when you're probably not fully mentally focused on making the decision versus pushing your baby out. And then the other thing is, having those discussions prenatally also gives you time to sit with it personally, right? And to work through the emotions of, okay, if I end up having an episiotomy for these various reasons, this is how I'm going to feel about that. Versus we know that birth trauma or a negative birth experience happens most when we don't feel in control or informed. And so even though we're not really, you'll never know if you need that episiotomy till you're in that situation. You'll never know how you're going to tear until you're in that situation, or if you will tear. Having that time to process it emotionally does really change the experience that you walk out of the room with. Or walk. Are wheeled up to the fifth floor.
Get out of there.
Yeah.
That's a very good point.
If you're looking for more information or support along your parenting journey, check out birthbabysleep.ca. That's where you're going to find prenatal classes, postpartum and new baby resources, and sleep support during the childhood years. Lastly, but certainly not least, if you got something out of this episode or our show in general, leaving a rating or a quick review goes a really long way to helping others find us. So please consider leaving one. That's all for now. I'm Ashley Cooley, and we'll see you back here next time.